So we've got some questions that we've been collecting online for you guys. And then we'll also take questions from the room and online. There you go. I know. I was twisting on it earlier. Or do you want to start with yours? I was just putting it in. All right, so let's go ahead and get a few questions. Whoop. Get a few questions going from online first, and then we'll go to the audience. And this is just open. They'll answer what they can. Certainly don't disclose any personal information about your medical history, as we would with any of them. And things that they may not be able to answer, they'll let you know that they can't answer them. Okay.
Okay. The first question from online, we'll start with a fairly simple, what I think is a simple one. Is it better to lower your calcium intake and increase your vitamin D in order to bring your levels up?
With vitamin D, you mean calcitriol?
They're on standard of care, it sounds like, and they want to know, is it better to lower their calcium and increase vitamin D rather than increasing the calcium?
Yeah, it's a good question, and we can actually fill the rest of the night with this, with the answer of this question. But so the relationship between the amount of calcitriol and calcium is a hotly debated topic, and there are strong opinions for one versus the other. The United States, by the way, has a reputation of giving the physicians giving too much calcium versus calcitriol. Some European colleagues say, well, I only give calcitriol because my patients take enough calcium through the diet. I myself like to not exceed 500 milligrams 3 times a day or 600 milligrams 3 times a day of calcium. You know, the recommended daily dose of calcium for non-hypopara patients, or everybody basically, is about 1,000 to 1,200. We heard this today. And so I personally try not to go higher than 500 3 times a day and then increase the calcitriol accordingly. And if somebody is on 6 grams of calcium a day, I mean, this is really, really hard. I don't know how people do this. And so I would increase the calcitriol. Now, having said that, you don't want to have no calcium or 500 milligrams of calcium or very little of a total amount from the diet and calcium tablets, right? So you want to have at least around 1,000.
I would add to that one advantage of calcium over calcitriol could be the binding of phosphorus. So especially if one takes calcium while they're eating a meal, that would help to bind up some of the phosphate in the diet and minimize the levels of that.
It's a great question, though, because I remember being taught that it was more calcium. I trained in the U.S., and then I'm talking to other providers and realizing, you know, don't be as afraid as a provider to increase active D. We just don't want to overtreat. We feel like if we're using calcium to adjust it more, it's safer, but that's not true. You can take too much calcium and you can take too much active D. So whatever we decide, what's most important is to get your labs frequently and to make sure you have the lab slips so you don't have to go through this rigmarole to get your labs if we make an adjustment. And that's one of the take-home messages, is to have that lab slip when you're traveling, like to a meeting, you know, and you want to get your labs, that you can do that.
And just to add a funny little story that some of you might have heard from last year, one of my patients got up and said, Dr. Mannstadt, you're responsible for me gaining 20 pounds. You said I should take calcium with meals, so I added a meal to every calcium that I took.
Oh, my gosh. I do remember that.
So you want to take the calcium with your normal meals.
Oh, that's funny. That's funny. Michelle, one more, and then we'll go to the room.
Okay, there's so many coming in. I'm sorry. I'm having to pick and choose here. Are there bone marker turnover tests we should be getting done besides a DEXA?
I don't think that it's something that should be part of standard clinical care. We know that people with hypoparathyroidism tend to have low bone turnover because one of the normal actions of parathyroid hormone is to stimulate bone to do its natural replacement. So in the absence of parathyroid hormone, the bone is a little bit slowed down or paused. So we kind of expect that bone turnover is going to be low. So I don't know what would really be gained from that in a usual hypoparathyroid patient. On the other hand, if somebody does have a bone mineral density test, also known as a DEXA, and they're having bone loss in that, which would be usually indicating that something other than hypoparathyroidism is hurting or affecting the bone, in that case, you would investigate what a potential cause of bone loss would be, and maybe looking at a marker of bone turnover would be appropriate in that case. But in the usual hypoparathyroid person, I don't think it's something we regularly need to do.
I completely agree. Clinical trials are a little different. There you want to measure all kinds of things, including bone turnover markers, when you use PTH-like products. And this is part of the evaluation of a new drug, but that is different from normal clinical care.
Okay, Bob?
Thank you for your time here today. When it comes to issues like diabetes, there was a notable difference once we were able to do at-home glucose monitoring. Has there been any progress in developing systems for at-home monitoring of calcium, phosphorus, magnesium, and other such activities? And if so, what stage are they in, and what expectations could we have?
I was hoping you brought us an update on that.
Oh, okay. Well, we heard at last year's conference this wonderful talk by a scientist from Virginia who is a chemist who is actually developing a, hopefully at one point, home measurement of blood calcium. And I'm always positively surprised and astonished about the success, because that sounds easy. This is hard to do in an academic setting. And that person in his group actually have made progress, has published about it, is trying to get grants, and it boils down to getting some money for the next step, actually. So if anybody is good in fundraising, this is one of a good way of doing that.
I
actually
noticed
have a
last year
response
is
to
that it's
that.
a lot harder than a blood sugar measurement, because you're like, why? You know, why not? So that was really informative last year.
I actually have an update on that. So I'm working with a company in California. We already have continuous metabolic monitoring. We're already doing human trials, and it's using interstitial fluid just like the glucose one is. And we've leapfrogged years past academia because you guys take too long. Sorry, guys. So we already have that. So if anyone actually has access to venture capital money, see me. But we are already doing human trials. So we already have a continuous metabolic monitor that fits under the skin where you can monitor these electrolytes continuously. Yeah, that's our commercial product. It's going to look like a patch, just like the diabetic one. Wow. Yeah. Yeah, it's already in use.
Yeah,
So-
we don't take it personal because we are not involved in
know,
the
no, no, I
development.
know.
But it would be nice if you can talk more about this development, because it interests everybody.
No, yeah. No, I know. I was just playing a joke because Lynn and I are always making jokes about academia versus private practice. So, the continuous glucose monitors, they use the fluid that kind of bathes your cells outside of the blood, right? It's like the lymphatic fluid. So like if any of you have scraped your knee as a child and sometimes it just bled clear fluid instead of blood, that's the fluid we're talking about. And that's what the glucose monitors are using, is that fluid underneath the skin. And that fluid underneath the skin is rich in information. It is communicating with your blood supply, communicating with your tissue. And so when you analyze that data, it is lagging a little bit behind the blood, but it is still the same information that's in the blood. And so we take that fluid and we can view it under certain patented sensors that will actually read whatever we target. So we are targeting hormones first, but you can target other things as well. And that's what we're in development. I was trying to figure out which ones we're going to target first based on who gives us money. So you give us money, we'll target your whatever you want to target. And so that's the device. And currently it's looks like an insulin pump. but we're designing it to be shrunk down into a patch device. So we're already using it. It's actually an approved device for use in research and in clinical trials. It's been around for a long time, the methodology, how you do it. But what we have done is we have patents on the way you read it, the way you sense the information, the way that information is captured and then relayed. So
we have some complementary studies going on at Columbia, also using what you described, the interstitial fluid. So I've partnered with a bioengineer at Columbia, and he's developed, it is like a little patch. I guess you would say it's like tiny Velcro. It doesn't hurt, but you wear it, and it samples this interstitial fluid, which is, like you said, reflective of the blood calcium levels. So we had one NIH grant, and we now have a paper in revision. Basically, we used hypoparathyroid rats and put this little sensor patch on them and did things like gave them calcium or gave them normal saline fluid in order to see their calcium levels fluctuate, and it does seem to work. So we've actually just applied to the NIH for the next level of testing, which would include some human participants as well. So it's still not ready for people quite yet, but I think for so many of you, it would just be a game changer to know, am I high, am I low, and to know it in real time, not 3 days later and not just an isolated snapshot. So I think that's really key.
That's fantastic. And Dr. Rubin, is that measuring ionized calcium or total calcium?
It's ionized.
Can I be your first patient? I'll volunteer.
We wouldn't have trouble getting volunteers. So.
Hi, doctors. My name is John Colleen. I'm a surgical patient. And just a quick question about the analogs. Do they have an effect on the incidence of kidney stones? Have you got any information on that? That's it. Thank you.
Well, Yorvipath has been shown to decrease urine calcium in a significant and sustained manner. It appears out to nearly 4 years now. So to my knowledge, none of the companies have the data on kidney stones or kidney calcification. We can extrapolate that from the reduction seen in urinary calcium levels that it's likely that kidney stones, kidney calcification, or kidney function would all have good outcomes from that, but that hasn't directly been proven yet.
And that'll be a really important point when somebody goes to their provider and says, you know, I know my calcium looks okay on paper. You don't feel as well as we want you to, and we want to protect your kidney. So that's going to be a really huge point. And I think we have enough data to push that forward in the real world. But when we follow people longer and we see their creatinine improving, their kidney function, and they're making less stones, then we'll be able to confirm it even further.
Hi, my name is Liz. I'm a post-surgery patient, 10 years. I got a question about calcitriol. So I was on Natpara before, but I'm on very high dosage of calcitriol, and I was taking 8 pills per day at 0.5 micrograms or whatever. And everybody I know is saying that's too high, and I've talked to my endo, and she doesn't want to put me on anything else, and she basically told me to go to another doctor. And I've had her for about 7 years now. I'm worried about my kidneys. I haven't had kidney stones yet, but I just want an opinion on what I should be doing.
And I know we're not supposed to and allowed to give individual advice. So the way I would answer that, but I'd love to know everybody's opinion, is that depending on your urine calcium, your kidney function, and your calcium in your blood, whatever you need is important to continue. But I like her recommendation to see somebody who is a hypoparathyroid expert, maybe has more patients, so that, you know, you obviously know so much about hypopara, and it would be very reassuring to make sure that that's really a high amount needed.
Yeah, I agree with that. And the only thing to add is 4 micrograms that you seem to be on of calcitriol is really a very, very high dose. And so that makes people very nervous. It would make me nervous, simply because, let's say, you're not absorbing it well, and then a week later you will absorb it well, then that would actually be dangerous because you can develop hypercalcemia. But that is typical for development and relationship with your doctor. If you both know about these risks or the unusual high doses, and that's what you need, and exactly it's what you need.
Hey, so my name is Kevin. I am a idiopathic caused hypoparathyroidism, but I was just going to ask what the big difference is between calcitriol, which I know is active vitamin D, and the D3 that we also take. And since you were suggesting to take the higher doses of calcitriol, what's the recommended high dosage you recommend?
Well, first of all, we cannot recommend anything for you in particular, but what typically is done, the calcitriol dose is found by changing the dose and measuring the calcium and albumin and everything else together, right? And so this is being done depending on the dose in certain steps, like 0.25 micrograms, and then you wait typically 3 to 5 days earliest to remeasure the calcium and go from there. So that's the general plan. There's no particular level. It's like insulin. How much insulin should I take? It depends, right? And so we just heard the example of a very high dose. So some people need more, some need less.
And then the difference from D3 is what we were talking about before. That's not active D, and without parathyroid function, idiopathic or post-surgical, you can't turn that D2 or D3 into 125 or active D. And I really like using the term active D. You guys know calcitriol and rocaltrol, but to a lot of other people, it sounds like calcium. So I really like saying active D for the 125 dihydroxyvitamin D. That's the prescription calcitriol. But I think this is a good point, and we're going to say it a couple times this weekend. When you switch from conventional treatment to parathyroid hormone, you really need to keep your 25 hydroxyvitamin D level adequate. You know, maybe 30 to 60. We'll see where people like it, and that's what takes D2 or D3, because you don't want to. You want to protect your skin. So I know you like to get sun, but you want to put on sunblock and take your vitamin D, because that's what you need for the parathyroid hormone to turn it into active D. And I know you've already heard that, but that's a huge point, because we have people that go on parathyroid hormone and they're doing great, and then all of a sudden they're not, and they forgot to take their D2 or D3. We know it's fat soluble, so you could probably forget it for 2 months and be okay, but that's a huge point.
Okay, Michelle, let's do some online.
I have one that just came in that asks, if you have calcifications, they didn't specify where they are. Is there any of the newer drugs that show that they can be reversed?
I think that would be our hope and wish. To my knowledge, there isn't any information showing that calcifications can be reversed. I think the hope would be that they could at least be halted, and maybe in an aspirational hope to be reversed. You know, we have our natural history study at Columbia, which I'll talk more about tomorrow, but that is part of what we're following, namely how calcifications progress over time. Can we predict who will be at risk for calcifications worsening? And we also have patients on PTH analogs to see, can the calcifications possibly be halted or reversed? But to the best of my knowledge, there isn't any evidence of calcifications reversing.
Okay. It'll be interesting if there's studies in the future to look at that, because in heart disease, we have meds that reverse calcifications. And so you wonder that, you know, you're treating your parathyroid status, but then if you have calcifications from before, could you be on one of those medications?
And this is for adults, right? In children, it's a little different. There are calcifications that can go away.
Michelle, would you?
Yeah, I'm sorry. There's so many. I'm just trying to read them all. Again, multiple people are asking, and I know this question was asked earlier today, but the presenter at that time did not know the answer. It says, does hypopara affect the immune system in any way?
So I think there is some evidence that infections can be increased in hypoparathyroidism. It's thought to possibly be related to lower levels of the 125 dihydroxyvitamin D or the active vitamin D. But data from Denmark, where they really have the richest data anywhere because everyone there is in the healthcare system, has shown that there is something of an increased risk in infections for people with hypoparathyroidism.
I'm thinking about moving into all the PTH drugs that we have that are coming to the market. Some people might say that if you're well controlled, you may not need to move to that. So from your perspective, what would be well controlled?
I think everybody needs a trial of parathyroid hormone replacement because well-controlled might be accommodation. You know, you guys are tough, and you know, you may be doing a lot, but if you look back, depending on how long you've had hypopara, you were doing more before, and idiopathic or genetic, you know, you don't know what it was like before. So, you know, I want people to a trial to protect their kidneys, what we were talking about. But I think that is going to be easy for you with your provider to make a case that a trial of parathyroid hormone would be important.
Yeah, the question of well-controlled, I was part with many of my colleagues in several committees and meetings to discuss that question. What is the definition of well-controlled? And we could not come up with anything really tangible because there are at least several areas that play a role. One is the symptoms, of course. So if somebody has daily symptoms, and what are symptoms is also a matter of discussion, you would say it's not well controlled. But what about somebody who doesn't have any symptoms but has a calcium crash once a year and has almost PTSD from that because it came without you knowing it comes, right? I mean, you could argue this is not well controlled. So these are symptoms. The other thing is findings, like if somebody has no symptoms, calcium levels is fine, yet there's calcifications in the kidney. You would also call this as non-controlled. And then another question is if somebody is on 4 micrograms of calcitriol and calcium, whatever the numbers are, is that well controlled? Well, maybe, but this is really a borderline-ish, right? And so there are many, many instances where you can argue, well, this is not really well controlled.
Yeah, and something that Michelle said earlier really resonated with me, which was that I didn't know that these things were even issues until I got on parathyroid hormone therapy. I can't tell you how many patients in my office say to me, well, it's probably just that I'm getting old, so I can't remember things, and how can I know if it's just like normal aging or not? So, you know, I think maybe even just trying PTH to answer that question would be enormously helpful to people who really aren't sure if they're well controlled or not.
This is a good time to share something really quick. I have a 73-year-old gentleman who's genetic idiopathic. You look back in his records, his calcium's been low for about 15 years, but not really low enough for anyone to, and make a long story short, his magnesium was low. Finally got him into the clinic. He said he'd had a seizure 2 days earlier, didn't call 911, he's a farmer. And it turns out his symptoms, he's, you know, working away, and he, you know, his symptoms are, feels a little anorexic. He's just not really sure, little stomach symptoms. And, you know, it's just unbelievable how something like that can go that long. And I know that he's going to feel so much better on parathyroid. So I was just shocked that it can be a story like that.
I think Dr. Kim wanted to add something.
Maybe a question.
Here.
I'll just holler. I was just wondering, just expanding on that question, if a patient's calcium is in the normal range and no other abnormalities in analytes, can there be residual symptoms of parathyroid hormone deficiency?
That's what I asked earlier.
We had that today already. Yeah. Somebody else should answer.
Yes.
It's also possible that that person might just not have a parathyroid reserve, so they might do some extreme exercise or have a viral illness and, can be fine, but with that extra stressor, the lack of PTH, would be revealed that they didn't have that buffer.
So Dr. Rubin, on what you just said, is there any evidence of, because amongst patients, we've had this conversation many times, is there a difference between those of us who have zero PTH, on standard of care, but our PTH is measuring 0, and those who have some, whether it be 10, 14, 15, is that what you're saying? Is if I don't have any to begin with, I have nothing to pull from. And so I may be having symptoms even if my standard of care got my number up to 8.5.
I can say anecdotally among my patients, it does seem to make a difference that I do have some patients who have detectable PTH, and it seems that maybe they do have some partial parathyroid residual function. But on the other hand, some of my patients who do have some low PTH levels seem to be as symptomatic and have the full other panel of biochemical abnormalities. So I do see sometimes that it makes a difference, but not always.
And what I ask the primary care providers in my community is if they're seeing a patient or the rheumatologist, a lot of patients see providers and they can't get an explanation for their symptoms. I say, look at their calcium. If it's less than 9, totally in the normal range, add a parathyroid hormone. This is just my clinical recommendation. And if it's less than 20, call me. Because I think that I think we all know that there are undiagnosed partial parathyroid deficiency.
Okay, we got a lot of questions in the room. We're going to go back to the room.
Hi, my name is Sarah, and I just wanted to know, is there a difference between the serum calcium and the tissue calcium? So what's in the serum might be, and are the different organs, does it matter?
Well, the main regulation is, first of all, through the serum calcium. The tissue calcium might have a little lag time behind this, but I don't think we know enough about differences between different tissues of calcium.
Yeah, we'll go this way and then that way. Yeah.
Hello. I think I asked a version of this question to Dr. Schoenbeck about the osteoporosis treatment with hypoparathyroidism. I would like your opinion, or those type of things, or what's recommended, or do you not know? So.
Yes. So it's a very important question because many people who have hypoparathyroidism can be early postmenopausal women, which is the population that's most vulnerable to bone loss. Fortunately, I think a silver lining of hypoparathyroidism is that bone tends to be thicker and denser, but let's say it's not. One option that could be appealing is to use Forteo, that is FDA approved for osteoporosis, and it would at the same time replace missing PTH. So I think that's a good option. That's one of the so-called anabolic or bone-building therapies. The other therapies that Dr. Schoenbeck also included were the so-called anti-resorptives that more block the cells in the bone that chew away bone, the bone chewers, which makes sense because we don't want bone to be chewed up in osteoporosis in women who are losing bone. But the problem is that preventing that chewing of bone also prevents calcium from being released into the blood. So we have to be very careful if we're going to use one of those medicines, and those are things you might have heard of, like Fosamax or alendronate, or one of the things that I think you asked about was Prolia or denosumab. So the way those drugs work is by diverting calcium away from the blood, into the bone, essentially, so it could worsen hypocalcemia. So I think they really need to be used with a lot of caution in a person who has osteoporosis. I have used them, but you really need careful monitoring.
And Dr. Rubin, would you consider measuring bone turnover markers in patients with hypoparathyroidism on conventional therapy who have osteoporosis and you're deciding upon the drug?
Yeah, I think that's a great idea because it could really help to inform you which way to go. Does the patient already have low bone turnover or is having normal bone turnover?
And the other thing I'd add to that, because men can have osteoporosis too and hypopara, but let's say earlier postmenopausal woman, if she had symptoms starting estrogen, which is a anti-resorptive agent, so we'd have to watch calcium, but that would help symptoms too and prevent the osteoporosis kind of long term, or a weaker anti-resorptive like raloxifene, Evista's been out 25 years, so it still could have the same effect of lowering calcium. In the future, if hypopara patients are on parathyroid hormone replacement, we could think, if it's working well, that we have a new baseline, and then we can treat carefully with all treatments we otherwise would.
And you might encounter people who tell you you cannot have bisphosphonates, which is Fosamax, reclassed, or other medications if you have hypoparathyroidism. You hear this often, and I would argue that, as exactly what Dr. Rubin and Dr. Schobek said today, you can. If you have hypoparathyroidism and you're on calcium calcitriol, you can have Fosamax or reclass or other medications. But first of all, contraindications have to be ruled out. You have to know about the medication, and the person who gives it to you, you really have to feel comfortable with and know how to check your calcium and to increase calcitriol or whatever you're on, if needed.
My doctor wanted me to ask you that question, or as many physicians. She wanted all the opinions she could get.
Hey,
So now you've got 5 different opinions.
there you go. All right.
Yeah.
Katie's. Or-
It's me. Today, several times was mentioned calcification, kidney calcification. It looks like this topic is worries many people, and I'm not very informed in this aspects. What is safer for kidneys? What is safer for kidneys? Calcium with vitamin D, let it be increased dosage, or calcium with calcitriol. Looks like in description of calcitriol, it is said that side effect can be also calcinosis. So what is, for example, I have my example. I could reach normal calcium level with calcium and vitamin D alone. Let it be like 3,000 units. And it keeps like at normal level. And I'm not sure, would it be better with calcitriol, which I tried, but I had skin reaction for calcitriol, like allergy. And what is actually safer for kidneys? What combination? Calcium with calcitriol or with vitamin D alone?
Well, I think in general, being able to use calcitriol would be helpful because the regular vitamin D has a long half-life. So I don't know of data about this, but theoretically having that hanging around for longer maybe could lead to a higher risk of high urinary calcium, whereas calcitriol is there and gone. I mean, that could be worse for hypocalcemia, but maybe would not increase the risk of a high urine calcium, maybe as much. But your case, I guess, sounds special because you haven't been able to tolerate the calcitriol. So yeah, it might be that in that case, figuring out the best possible regimen with calcium and parent vitamin D is what's necessary. The other thing to think about is hydrochlorothiazide, which is a water pill that helps to lower urine calcium levels and to raise blood calcium levels. So sometimes that could be a helpful thing to add into the picture.
Okay, Bob?
What can be also, one second question, what may be symptoms of vitamin D toxic effect? Like today, Dr. Schoenbach mentioned like about 3 up to 4,000 units could be considered safe. And what would be toxic effect of high dose?
Right. So I think when she said up to 4,000 units is safe, that's true. But I think most people really aren't on that high a dose usually. I mean, of course, everyone's different and could have low levels of absorption. But vitamin D toxicity really would lead to hypercalcemia and hypercalciuria. The urine calcium would probably rise first, but then the blood calcium would rise. And the symptoms are those of a high blood calcium. So someone could feel nauseous, constipated, lethargic, increased urination, increased thirst, headache. So it's really the hypercalcemia set of symptoms with vitamin D toxicity.
And usually the vitamin D level, is over 200. A lot of times the reference ranges in anything aren't accurate. You got to be careful looking at the reference ranges in your labs. It's better to ask your provider, is this really accurate? Because sometimes it'll be 10 to 150. We know we don't want vitamin D 10. Thank goodness it's not that low on the reference ranges anymore. But 150 is high. I mean, we kind of like it 30 to 60 for vitamin D levels. But if people take 50,000 a day and don't have hypoparathyroidism, they can definitely become toxic, maybe somewhere over 10,000 units of D3 a day. But you're a different situation. If you're allergic to the active D, it'll be great to get on parathyroid hormone replacement if you can, and then maybe you won't need either calcium, aside from your diet, and active D.
Thank you. Yeah.
Okay, we're going to go to Bob. We can take one more in the room, and then we're going to take one or two online, and then we'll be finished.
Thank you. Hello again. In our community, we often hear the question, I can't find a provider in my area. There isn't an endocrinologist who actually knows about this condition. And I know in my own journey, I've had to go through several endocrinologists who have even had on their website and in their profile that they've dealt with this condition, but then once I get in there, they really haven't. They've maybe had a 20-minute seminar in med school once. So my question to you is, what advice would you give patients who are newly diagnosed or looking to find a new provider in their area, as far as questions that they can ask in their first appointment, and that intake appointment with that new endocrinologist that might give them some insight into whether this doctor is actually knowledgeable and cares about this condition, since it is rare?
I liked what you said, Michael, where, be kind, be respectful to your provider, but also be firm. And I think this is one of our missions of the Medical Advisory Board, is to put together some questions. And there's that fine line, because you're very knowledgeable and you want to go in and be proactive. On the other hand, you don't want to kind of shut the door before you even give somebody a chance. I'm hoping that we'll be able to have more virtual subspecialties in all of endocrine, because there aren't very many of us anymore. Hopefully there'll be more in the future. But so that, there'll be some virtual endocrinologists that can help your endocrinologist. This doesn't really exist too much yet. But then to go to the big universities, even if it's only every couple years, and see people that do the trials, that's what I would love if happened.
Yeah, and asking how many patients with hypoparathyroidism does the provider see is a question you can ask. It depends on how you ask it, and if it's the first question, might not go too well. But then there are, of course, physicians who might see certain diseases rarely, but are really good physicians and really care about it, and others who might see more patients and don't really have a deep interest, right? So that's another nuance that you might have to figure out. And I remember Jim Sanders, I think, he and the primary care physician where he lived were working very well together, right, and developed an amazing relationship. Bob.
Yeah, that was Dr. Barry Bennett, and that guy was phenomenal. And I was just going to add to this conversation I live in a very small town up in northwest North Dakota, and we don't have, number one, we don't even have endocrinologists. All we have is a PCP, and I travel to the Mayo Clinic once a year with my daughters for just, to follow-up appointments and whatnot. But as we went through the pediatrics, we actually went to 2 or 3 of the pediatricians in the area, and like Dr. Mannstadt was saying, a lot of it was finding somebody that cared enough to want to learn. And that's what made Dr. Bennett so special, is that he did want to learn, and he took the time to talk with other doctors and do his own research, and then develop that. Even though he wasn't an endocrinologist, but he was able to not master it, but develop a pretty good understanding of how to treat this disease. And now I have my current PCP for my daughters. Now he just retired, unfortunately, and we found another one. But he's willing to learn. He's willing to reach out to Dr. Tebben over at the Mayo Clinic and talk to him. You just gotta remember that the doctors work for you first and foremost. It's not the other way around. And if you're not happy with them or what they're doing, then sometimes you're just going to have to cut the cord and leave, find someone else. But you can find them.
Very good. Michelle?
Before I ask this last question, I do want to add to that as well and say, yes, I agree with both Bob and Dr. Mannstadt. And I think the key is you don't need to necessarily be looking for an endocrinologist. You need to be looking for a provider who is willing to go learn with you and listen to you. And that's much more important. If they're willing to listen to you, you'll get much farther than worrying about whether or not they've ever seen a hypopara patient. They don't have to see one if they're willing to work with you. So on that note, we have a question here that is asking about K2, and is K2 necessary for calcium absorption? And you're all looking puzzled. We get asked this question a lot on social media.
I think there are a lot of things that are over the counter and added to calcium that really don't have the science. Now, there was some interesting vitamin K data 20 years ago in the Nurses' Health Study, but it was never validated. And so, especially because many of you are taking more than 3 calciums a day, it's important that you don't buy something that has a lot of other things in it. And, you never know whether something's really in what you buy over the counter. And so you don't want to buy the best deal calcium because it might not even be in there, and that's tricky. Any other vitamin K?
I don't know if the origin of that is because one of the bone building associated proteins called osteocalcin, it needs vitamin K for it to be like fully activated or carboxylated. But even if that's the biologic basis behind the question about vitamin K, I don't think there's really solid evidence to support using it.
Okay. And we're actually gonna give you guys one more, and we want to hear from each one of you on this, if you can. This is going to be a sort of a Patty and I question that we've pondered based off of things we've seen on social media. Do the doctors have a perspective on what you think a crash is? We know that patients have a different definition of what a crash is, and as we start to go into PTH therapies, do we need to be so cognizant of the number? Does the number matter as much anymore, or is it all about how you feel?
I'll start. I think that's one of the main messages this weekend, is to be able to describe your symptoms, because it's almost, it's like pain. People have different thresholds of pain. And so, that score of, what is it out of 10? I think that helps, for pain. And so, we've got several different scores for hypopara symptoms, and we try to simplify them. And last year I kind of presented one that we used with HPES. But crash, to me, and I really ask my patients how they define it, but to me, it's where you can't stay home. You can't drive. You don't necessarily need to call 911, but someone needs to get you into urgent care or the ER for IV calcium or fluid. So to me, that's how I define a crash. It's a 10 plus. So if 10 is the worst symptoms, then it's a 10 plus. And how I define, with my patients' help, a 9 out of 10 is you're not necessarily going to the ER, but you're hoping it's very, very rare and it's very, very serious. And it takes a long time to get better. And anywhere from, a 3 to a 6 is where I think most of my hypopara patients live. And it could just be for a few minutes. It could be for a few hours, depending on how active they are. But the bottom line is everybody's so different, but if you can write that down, try to simplify it and really give it to your provider, because you're coming in looking good and they don't really understand at all what you're going through. So I think that symptom discussion is really important.
Yeah, my understanding of crashes mainly come from one patient who really described it very well, and unfortunately I had to see her also in one of these situations. She wakes up in the morning, feels like she's hypocalcemic, has symptoms, numbness, tingling, and takes calcium and is getting worse. And she feels something is coming. Her whole face gets numb. It's like a mask, and she knows this is going to be bad. A general feeling of doom, basically. And then the hands curl, and she takes calcium like crazy, but it doesn't help. And she has to go to the ER to get ionized calcium, right? So a relatively sudden, doesn't have to be minutes, it can be even a day or so, of severe symptoms of hypocalcemia that are not stoppable easily by some calcium that patients typically take when you have symptoms. And that's just horrible. And takes away your entire control. It comes randomly without any reason, or we try to make sense of that. And even in the ER, they take always or often quite some time, especially busy ERs in cities, to get this calcium running. And I was there, and I told them now, and they said, we ordered it, and So it is really a very serious and terrible condition. And the calcium is low. Of course, which level of lowness, that is very different from patient to patient, and we heard this today. I have also a patient at 6.5, no symptoms, right? And others might have these severe symptoms at 7 or so. So that's kind of how I see crashes.
Yeah, I echo that. I think it's absolutely terrifying for the person who experiences it. And I think it's a constellation of physical symptoms that could be different for each person. So it's kind of like a clinical diagnosis, and I think the low calcium level helps to confirm it, but I don't think there's anything like a cutoff that we could use for it.
Okay, and just real quick though, the second half of that question was, as we go into PTH therapy and people's numbers maybe are still a little below normal, at the edge of normal, but they're no longer symptomatic, do the numbers matter as much anymore? Or just is there not enough evidence to know that yet?
I think the numbers matter, but I think the range is going to be wider, and we're going to be able to ask you, where do you feel? Where can you do the most? Do you feel better at 9.5 rather than 8.5? Or are you okay close to 10? I mean, that's scary to be up at 10, but if your kidneys are good and your urine calcium's less than 200 milligrams a day, we're going to have that flexibility. I think the crisis versus crash, when we're just getting back to that because it's related to the numbers, is that it's also individual, and if somebody's using the word crisis because they're afraid that it's going to get worse, that's okay, just as long as you communicate that to us, to your providers. And that way we can make sure that we don't end up with a 10+ severity of a crash in the hospital.
Yeah, and if the serum calcium is 8.5, lowish, or 8, and there's no symptom and no objective impairment of muscle strength, etc., I'd be fine with it.
Yeah, I don't know that the PTH analogs fully disconnect symptoms from the numbers. I think you would still use both pieces of information to decide what's going on.
Excellent.
Okay, and I promised Katie she could have her own question here before we end.
Thank you, Patty. Hi, doctors. And I apologize in advance for this difficult question, but I haven't had the mic all day, and so I saved this one just for you. So, from my own journey and experience, many of us, as you know, have had, thyroid cancer or something with the thyroid where it's been removed or partially removed. And so that's a common comorbidity that we deal with, adjusting simultaneously at times, or at least in my situation, to being, post-surgically hypothyroid and hypoparathyroid. And so I remember personally dealing with a lot of symptoms that overlapped between the two, and it was difficult at times to dissect the differences. And so I was wondering, perhaps for those in the room or online with us that might be newly diagnosed or going through a similar circumstance, how do you all approach making that determination in how to treat people with both of those difficulties? And what can we as patients become aware of, and how can we describe our symptoms from each of those things in a way that's helpful to you?
I can start with that. It's an excellent point, and because calcium is so variable in your everyday, not just how much you're trying to take in, but your levels, you're going to need your thyroid checked at least every 6 weeks to 10 weeks, in my opinion, unless you're not making any changes, which is rare, in your calcium. And I know you try to separate your calcium and your thyroid by 4 hours, but to me, your calcium's number one. Maybe not when you're on parathyroid hormone replacement, you can take your calcium later, but I want your calcium by your bed. I don't care about the thyroid. Of course, I do thyroid dose before your calcium. Maybe you could take the thyroid later at night, depending on how late you take calcium. But I think my patients like their TSH to be between 1 and 3, and if you measure it regularly enough, I think that when your TSH is stable enough, then you're going to be the one that helps us differentiate between your thyroid and your hypopara symptoms, because they do overlap. I mean, when somebody's TSH is 30, very hypothyroid, the most clinical sign is this unbelievable chill, kind of cold. It's not dry skin or hair or fatigue or constipation, because those symptoms are everywhere anyway, but it's this chill. And then if you're over-replaced because you went on parathyroid hormone, you're not on very much calcium, and you haven't dropped your thyroid dose yet, you can be anxious and hot and tachycardic, and that's dangerous for no matter how old or young we are. So it's such a huge, important point.
Well, I typically tell people about the TSH as really a very, very good marker of thyroid replacement and sufficiency, and that this is really the finest marker that we have. It's so sensitive to smallest changes. And I also tell people that is generated in your brain by cells that monitor the thyroid hormone levels. So it's your individual body's response to the levothyroxine or Synthroid that you're getting and telling us whether this is the right dose or not. I know life is more complicated, and so is medicine, and there are always exceptions to that. But as long as the TSH is in this range that we target, like 1 to 3 or so, the symptoms are unlikely to be from the thyroid.
Yeah, I think we want to approach both of the two problems optimally and really range, our goal is to have perfect levels in both, so not to overlook the thyroid either, and target for it to be normal.
All right, well, let's give it up for these fabulous experts. Thank you so much. All right.